Today I'm presenting a talk on importance of molecular diagnostics in hematology, but that is almost related to all of the oncology. Many people, I mean, few of the pathology people also already have heard this talk, but because it is contemporary and important in day-to-day scenario, also the future student need to be very well versed about the techniques which we use in molecular diagnostics, because everything will depend on the molecular diagnostic in coming days. So I'll start. This is my structure. You can see here, I'll go through basically from some of the basics with the PCR, because that is what which defines the molecular era. Some of the modifications of PCR, then coming to the both the techniques of sequencing, which is Sanger's and next generation sequencing, and how we use them into the prognostication and risk stratification of the diseases. And finally, I'll give few of the example, 2, 3 cases to just to summarize or give you a brief overview that how these intricate diagnoses can be made based on the information from the molecular diagnostics. So as you can see here, very small, a very simplified diagram where you have a cell and a nucleus. In nucleus, you have chromosome, which is made up of histone, and DNA is wrapped around like a ribbon on that histone core. And that DNA has your gene. So your gene is basically a code, which is AGCT, 4 bases, 2 purine and pyrimidine. Okay. Now, if you can look things into the microscope and give a diagnosis, you call them cytogenetics. As simple as that. If you can't look into the microscope to make a diagnosis, you need PCR or something else, then you call those tests as molecular tests. So I'll be covering mostly molecular, will give brief idea about the cytogenetics also. Now, this one picture encompasses all the human development, central dogma of molecular biology. That means you have a gene, which is a DNA sequence, which has intron and exon. And from that, there is transcription. You'll get an RNA. After some processing, your mRNA will finally translate it into the protein. Protein is a three-dimensional structure, working horse of the cell. They will do the final work. So you can see here, the king is sitting in his room peacefully, and he is just ordering your artillery people or other people to work. So protein is working. Now the same central dogma is written here. Can you see this? This is your king. Look at the size of amount of information this DNA has. This is your DNA. But do you need all that information? No, you don't need. This is your mRNA. So look at the amount of information which has reduced from that much to this much. Finally, this is the protein which actually works. So look at the amount of information. But that doesn't mean that rest of the information which is there in the DNA is redundant. This is important. Now, why this is important? We initially in the current scenario only we started coming to know that okay, intron, which is not really transcribed into any of the protein or mRNA, are also important, because when you look at the some of the tests or the drugs like hypomethylating agent azacitidine or decitabine, they work by interfering into the methylation of the protein, which is gene modification, not actually the gene. So they act on introns, which is non-transcribed part of the DNA. And then by working on introns or non-transcribed part of the DNA, they change the transcription of the gene. So activation or repression. And that is how they work. Now this is the same information of the DNA is given here. Now this is the data which we get from the Sanger sequencing. Now how we read it, in coming slides I'll tell you. So first coming towards the, should I hold this or I'm audible? Okay. So we have the mutations. Any change in the DNA is known as mutation. Now there is a difference between polymorphism and mutation. A mutation which is more than 1% in any given population is called as polymorphism. and less than 1%, it is called as mutation. It's a protective mechanism because God does not want more than 1% population to die. Suppose if the Gwalior population, more than 1% of Gwalior's population has any deadly mutation, how many people will die? So therefore, those who has more than 1% or generally benign mutation or those who favor survival. So we call them polymorphism. Now these are different type of mutation, substitution, deletion, insertion. Basically a purine will change, A will change with G or C with T or कैसे भी हो सकता है. So you call them either substitution kind of mutation or transition or transversion based on that. Now this is the point mutation, what it does. So here you can see the DNA AAAGCT, it's written here. What is denote? It is UUU, and what is forms? Phenylalanine. Now when something happened there at the last base, what will happen? This change from TA, so it will form leucine. Now look at here. If this scenario comes here, the stop codon will come because this T will form what here? So UGG, UUA or UGA, like that. So stop codon will come, and once the stop codon chain will terminate, there will not be any more protein formation. Similarly, frame shift mutation or deletion insertion can cause different changes in the protein expression, or they can form any harmful protein. Now, with that background, now the moot question is, what are the common techniques we have in our armamentarium, and how do we choose a particular technique for particular mutation? Now here you can see on the left there are many mutation which is there. On the right, in the middle and last column, there are techniques which are available. So when you see here, if you want to look at the mutation, which is point mutation, substitution, deletion or insertion, you use either capillary sequencing, quantitative PCR or digital droplet PCR. Of course, NGS will give everything of that. Now, if you want to look at chromosomal aberration, copy number gain or loss or deletion, you do FISH, ISC, MLPA, or you do a normal karyotype. Now, for translocations and fusion gene, again you do FISH, ISC or RT-PCR. Now, if you want to do everything, you do massive parallel sequencing, that is NGS. But NGS also has its limitation. As we know, large deletion cannot be picked up by NGS. Because NGS work on a basic principle that you need to fragment your DNA into less than 1000 base pair segments. Now, if a deletion is more than 1000 base pairs long, you generally can't pick. Entire segment has gone. So that segment is not at all there. Then how will you detect it? Now, this particular paper of 1989 emphasized how PCR has actually changed the molecular diagnostic era into two parts, pre-PCR and post-PCR. Everything is dependent on the PCR. NGS is also PCR, but simultaneously they do PCR on thousands and millions of fragments. So we call as next generation sequencing. Of course, Carrie B. Mullis got Nobel Prize for PCR. Now, these are the components of PCR which can affect a PCR, a template, enzyme, primer, buffer, product or program. Template is basically a sample of DNA on which the other fragment will form. Then you have enzyme. We have Taq polymerase here that works on a 90-degree temperature also. Then you have primers, then buffer, product and program. These are various variations of PCR which is available in our country and around the world. Look at the amount of different kind of PCRs we have. You don't need to remember all these things. You just need to remember that we have a point mutation deletion. I want to send a PCR or a Sanger sequencing or a NGS. That's it. I want to look at translocation. I want to look at gene deletion or something. You send FISH or karyotyping or anything like that. So this is a real-time PCR. How it works? So this is basic principle. This is a DNA. You want to copy that. You have a primer attached to here, and this is your Taq polymerase. ये ऐसे ऐसे आगे बढ़ेगा और ये पूरा स्ट्रैंड ऐसे बनाता जाए. Now, it's not simple PCR. It's a quantitative PCR. So what it does, you have a probe already attached here, which has a quencher C and a reporter Q and R. So if the quencher is attached to reporter, that means the probe is intact, then there will not be any fluorescence. You can see here, intact probe, there is no green fluorescent. Now, what does Stark polymerase does? When it replicates the entire DNA, it breaks whatever comes in its way. So the probe is coming in way of Stark polymerase. It will break the probe. Quencher is detached to the reporter. Now the reporter is, it's like sun. You can see here the green fluorescence is coming up. So the amount of fluorescence will be more and more with each cycle of PCR. And the whatever amount of fluorescent maximum amount we are detecting, that is proportional to the number of copies of particular mutation or virus is present there in the initial material. So this is how RQ-PCR works. This is the same famous graph. Many people must have seen this in COVID era. CT values you must be knowing. कितना तुम्हारा CT है बड़ा famous हुआ था. This is cycle threshold. This is what cycle of PCR at which your product starts showing amplification. And this is the maximum amplification. Okay. So this is the standard curve. How will you do that? एक आपके पास standard curve होता है, उससे आप compare करते हो आपके product का जितना fluorescent आया. जैसे हम BCR ABL का कभी QRT PCR देखते हैं, it's very simple. Look at the ABL copy number. ABL is the housekeeping gene जिस पे वो compare कर रहे हैं BCR को. Although it's a fusion also, but ABL act as an internal control or a housekeeping gene also. So on that basis, you can detect how many ABLs are there and how many BCRs are there, and therefore you can give the copy number exact. This is how PCR evolved over the time from the starting endpoint PCR. So what is the endpoint PCR? Endpoint PCR means whether the DNA you want to see in particular specimen or mutation you want to see in particular specimen is there or not there. Endpoint PCR will tell only this. Then generation 2 is real-time PCR. Now if that mutation is there, what is the load of that mutation? What is the copy number of that mutation? That will tell real-time PCR, which we call it RQ-PCR. Then the third generation is digital droplet PCR. Today's era is of digital droplet PCR. Sorry. This is the digital droplet PCR. It works beautifully, divide and conquer. So you take the specimen, mix some oil, and there will be droplets. So each droplet will have one PCR reaction separately. Now whatever droplet is positive, you report them positive, and how many droplets are positive, it depends on the copy number. So it's very simple, quantitative, and there is no mixing in that. So this is very sensitive, very specific, and highly accurate. So it's simple. Now real-time versus digital PCR. So you can see here, this is analog real-time PCR. You calculate so much of mathematics is going on here, delta CT method, delta RN method, and so many things. But here you can see nothing. It's as simple as that. You divide into the drops. Some of the drops is positive, green fluorescent. Some of the drops are negative. You count positive and negative cell and do an absolute quantification. Now benefit, absolute quantification as I mentioned, precision, reproducibility, sensitivity, accuracy. Now, why I am telling this to you? It is not because you need to know this or mug this up. No. You just need to know, okay, this technique exists and what my lab is doing. You have to ask questions to your reporting or the lab reporting person. Okay, sir, what techniques we have, what we can do, what you are doing, how you are reporting, and then only they will be interested and on their toes. Otherwise, they will be sitting there reporting anything, you will be looking and treating patient accordingly. So the critical analysis is only happen when you know the subject. Now coming, I have done the PCR and there is a product of the PCR which is available, yes. But what is the sequence of that product? How AGCT is there on that product? That is the moot question we want to know. So Sanger sequencing is the first technique which used to determine what is the sequence of nucleotide in a particular piece of DNA. So we have many techniques. Gold standard or oldest technique is Sanger sequencing. Then we have pyro sequencing. Then now we are using NGS. Sanger sequencing is very time consuming because one by one small fragments you have to do sequence. 32 billion base pairs are there in human genome. And that is why when Human Genome Project was established in somewhere around 2000s, and it took 10 years for them to sequence the human genome. And the result was we have 20,000 gene which works. So whole world was astonished. How is this possible? Only 20,000 gene which is working. Where is the rest of the nucleotide which is doing? Now, so then come the concept of epigenetics. Okay, the rest of the gene which is not there is, they thought it is non-functional, but those are not non-functional. They are controlling the expression of your 20,000 genes. Okay, so this is how Sanger will work. You need not to go into the details of the techniques basically. You just know how it works. So for given template like DNA, it's like PCR, except PCR use single primer and polymerase to make single stranded DNA. It includes regular nucleotide A, G, C, T for extension, but also include dideoxynucleotide. तो क्या होता है कि जब आप पीसीआर करते हो तो आपको एक एंजाइम चाहिए, स्टार्टिंग मटेरियल भी तो चाहिए. व्हाट इज द स्टार्टिंग मटेरियल? एजीसीटी. सो एजीसीटी उसको मिलता जाता है एंड वो आगे आगे बढ़ता जाता है. नाउ इन सेंगर सीक्वेंसिंग यू ऐड डाइडिऑक्सीन्यूक्लियोटाइड आल्सो. सो व्हाट दोज न्यूक्लियोटाइड डज, these are simple, these are dideoxy. What they does, they are labeled with fluorochrome and terminators. So how it works? You can see here, this is the known part of your sequence of a fragment of DNA. Rest the question mark. You don't know the rest of the fragment. So you can attach the primer here and then you do sequencing. Okay, so primer came. Now, how? Your Taq polymerase will come and will form till here. Now here comes your dideoxynucleotide. Whenever the dideoxynucleotide comes, chain will stop there. So what it means? It means you got a 21 base pair fragment, and you know that red color denotes thymine. Now, similarly, the next one will come. Again, this happening. It stopped at C. The next color came, blue color, 26 base pair. Green color came. Now it will stop at random places. So what will you do? You actually see the length of the base pair and arrange them in last of 20, 21, 22, 23. Okay, so each length is denoting one peak. Green, blue, red. So it happens like this, like this. So you pass a laser light and fluorochrome will come. See this. One peak, two peak, three peak. So you know what color G denote, what color C denotes, and all these things. So similarly, this happens like this. It keeps on, it gives you this data. Can anybody read this data? No, nobody can read this data. This is so clumped. So what they did, the program or the software does the job for us and it will do like this. Separate it. Here you can see GCTG, GCTG, it's like that. Now, with that data, you take out this data and paste on a blasting platform. So blasting means the software already has, the free software is available, NCBI or human genome softwares are available. You copy this, your data and paste on that and enter the button, identify the mutation. It will give you the mutation. Okay, this has this much, this part is changed and this denote this mutation. Now, slowly you're doing the job, you will come to know that you know most of the known mutations and therefore you can report without looking at the blasting also, but they are there to help you. It comes immediately. Okay, so advantages of Sanger sequencing: lowest error rate because you are doing very small part at one time. Now the cost is very high per base. Then the long read length long time to generate, gold standard, but amount of data per run is very less. Now, this is the Moore's law, which we use in the transistor or the computer industry. So this particular person told that amount of transistors placed on one chip doubled every year, and therefore the size of the equipment or computer is reducing and the cost is also reducing. Similarly, because this is happening in IT era and NGS use a lot of data analysis and IT industry incorporating into that, so the cost is also reducing. Here you can see 10,000. This is per base cost, per base. Remember, एक base का cost 10,000 था 2,000. तो पूरे human genome का cost कितना होगा? 32 billion base pairs. So therefore, entire world came together and did that. अकेले किसी से नहीं होना. Now you can do NGS or whole exome sequencing in some 20,000 rupees. So see how much we have come up. Now the days are not far ahead that we will be able to do NGS in 5,000 or 6,000 rupees. These are various machines which are available, and many of them are available in India also. Again, NGS sequencing machine. This particular iron torrent is available in Christian Medical College, Vellore, and this is also available in TMC, Kolkata. So the question, what are the common diagnostic strategies using next generation sequencing? So now we have a patient of AML and I want to send NGS. Now what options I have? What can I send and where can I send? So three options I have. Either I do whole genome sequencing. I do entire genome. I call lab med genome people, Dr. Charu, please do whole genome, entire genome you sequence. Next question he will ask, why are you doing this? So then you need to find out why I am doing this. So here you can see you do only exon part, because intron is not really mattered here. Or you can do targeted only. So Dr. Charu will tell you, sir, we have known mutation list available in AML. Why don't you send only those mutations which matters or prognostically important? So then you will say, okay, yes. So that is called as targeted sequencing, which we send routinely in breast carcinomas or AML or ALL, everything. Then you have RNA sequencing also. Now, why RNA sequencing is important? Because some of the mutations are splicing junction mutation, which happens only in mRNA. They will not be represented in DNA. Also, some of the fusion genes which are there, they will be represented in RNA only. Some mutation in RNA only. So those mutations will not reflect if you do only DNA targeted sequencing. So when you look at the AML, that targeted test available in the gene list available, they do both DNA and RNA. So nothing is left. Yeah, this is the same thing, targeted, how they do it. They detect gene fusion, they detect gene expression, they detect copy number alteration, they detect insertion deletion and single nucleotide variation. If you have a ALL or AML and you want to send an NGS, it's very simple. Take some peripheral blood, send. No need to do marrow also. Now, but you need to send in cytogenetics also. This is a problem. Why? Because ELN 2022 still tells that complex cytogenetics at a bad risk. And complex cytogenetics means 5-6 chromosomes came together, 3-4 abnormalities of chromosome are there, which cannot be detected by NGS. So therefore, you need to send cytogenetics also. And to do cytogenetics, you need to do bone marrow. Only way peripheral blood cytogenetics you can send when you have 80-90% blast in the peripheral blood, because they are immature, so they will really proliferate. Otherwise, you can't. How do you report these variants? We have discussed when Dr. Charu came. Tier 1 variant, strong clinical significance. Tier 2 variant, potential clinical significant. Tier 3, unknown clinical significant. And 4, benign or likely benign. Tier 1 is strong clinical significance. That means you have either level A or level B evidence. That means strong, good designed clinical trials is available. Drugs against those targeted mutations are available. Then you have really strong evidence. If you do not have such good evidence, that comes into tier 2, potential clinical significant, or some of the trials are going on. There may be some therapies in near future which can come up. Now, risk stratification. How do we use this information? This is, we'll quickly go through. You can see here the ELN 2022 most recent risk stratification system of acute myeloid leukemia. Now look at the amount of mutations are there in the bad risk. If you do not do an NGS, you really can't tell patient and the family that either you are in good risk, intermediate risk or bad risk. Now why this information matters? Because poor risk patient 5-year overall survival is only 10%. So your patient will come after some time when he relapses and tell, sir, why didn't you inform me about this? So it's a legal matter now that you have to do all the tests, or you have to inform the patient that we need to send an NGS to correct prognostication. If they tell, okay, I'm not willing, so then you can write on the file they are not willing for the NGS. Otherwise, you have to send NGS. You have to tell them all the information. An AML patient will survive how long you don't know. 20 years, you will be old, sitting at your home, and he will be coming to you to sue you in the court. Sir, you didn't told me any information regarding that. It will come up or anything. Now, similarly, in the ALL, you have so many mutations which is there, which used as risk stratification. In myeloma, mostly we do not send NGS. Only if you send a myeloma FISH panel, that is sufficient, because most of the information you will get from these FISH panel. This is 6,000 rupees approximately cost, and you can send it to the MedGenome or Core or wherever you want. Again, in the CLL also, you need only to send FISH. No need to send NGS. NGS is important for ALL and AML and some of the benign like aplastic anemia. Now, these are the targetable mutation which is available. Drugs are available. You can see midostaurin against FLT3, ivosidenib, inacidenib, and all those venetoclax and everything. These are available. Some of the drugs against TP53 are under clinical trial. So ALL also, Glina and all, basically these are based on the surface markers, but they are also available and works. pH like ALL, if you know it's a bad risk, and you can use tyrosine kinase inhibitor in some cases. For CLL and multiple myeloma similarly. Now coming to the cases, some of the important cases only, students need to pay attention here. So you have a 27-year-old gentleman who presented with pancytopenia, who has a history of receiving ATG for aplastic anemia at the 8 years of age. When he was 8 years of age, he was diagnosed to have aplastic anemia and received ATG. Now he is 27-year-old, came to me in general OPD. We did marrow, he came with pancytopenia, so we did marrow aspiration biopsy plus flow and NGS. NGS was FLT3 positive, flow was suggestive of AM. We need to understand that 30% of the patients of aplastic anemia who are treated by immunosuppression will be transformed into AML or other malignancy. So this is clonal evolution we need to understand. And therefore, now slowly the time is coming that most of the hematologists are now referring patient, if they are younger than 40 years, for the transplant. You do transplant, so avoid that 30% risk. Of course, transplant has its own risk, but still, this 30% is a big chunk. Now you see that patient, we gave 7+3 induction, it was failure. He has a refractory disease, not responded with 7+3 induction. But he has FLT3 positive. So what we did? We gave one targetable medicine available, midostaurin against FLT3, azacitidine with venetoclax. And with only 2 cycles, he became MRD negative. So this is how sometime it works. So therefore, because we had the information of this FLT3 available. Now then we did, because he was refractory to 7+3 and intermediate risk, we did hematopoietic stem cell transplant with 55-year-old father as a donor. That was a different story, because father was having coronary artery disease and he didn't reveal it to us. And we gave conditioning to his son And when the time came of the, harvesting of stem cells, so we sent it to the blood bank. Now blood bank was doing there. So they took the history and they refused for the harvest. They said, no, he has coronary artery history, I can't do. Now, if you gave already conditioning, the child will die if you do not give them a stem cell. So we explained to the patient, blood bank people were still refusing, okay, we will not give. So what we did, we took on our onus and the father gave in return, okay, I am ready to go through this procedure. We took in BMT unit only, all the stem cells we have taken out and given. Now look at this NGS report. He has FLT3 and WT1 positive. That we already know. Here what you need to see is the variant allele frequency, VAF. FLT3 was so low, but still we gave a chance and gave midostaurin and somehow it works. Now this is a problem. Anything else you want to do on this patient? I already shown the next slides mistakenly, but do you want to do any other test? Think, because he was aplastic anemia. Why he was aplastic anemia in childhood? So you need to send that NGS for inherited bone marrow failure syndromes. Now we send that and look at that. RTEL1, dyskeratosis congenita. Now you are doing transplant with the father and he has DKC positive, RTEL. Now what extra test you want to do? Test father, whether the father is positive for DKC or not. This is the problem. Father was positive. Present heterozygous, but here is the situation, asymptomatic. So we discussed in our transplant meeting. So I said, I gave my opinion, okay, we can't transplant this. What if he again develop RTEL? So our HOD told, if father is not developing till 55 years of age, that means it is unlikely that only RTEL is causing this aplastic anemia. There must be something else, which is the second rate, which is causing aplastic anemia in son. So therefore, we should take a chance and transplant. Mother was not there, so we can't do anything. No sister. So we did transplant and he is still surviving. This is the chimerism report, which you can see here, 100% chimerism after 1 year. This is a split chimerism. In that, they take out the T cell and myeloid cell separately from the peripheral blood and check whether they are donor cells or the recipient cell. So if the T cell is good there, that means you are okay. Why? Because T cell only required to kill the leukemia cell, so the chances of relapse will be zero if the T is good. Yeah, again the second case, this 24-year-old lady with all absolutely normal physical examination, no significant past history, came with pancytopenia. We did marrow aspiration, diagnosed to have severe aplastic anemia. We did that chromosomal breakage analysis, but because TLC was only 400, so we could not get the results as per desire. And the patient was pushing to us, why you are not doing transplant, why you are not doing transplant, this is so much of delay which is happening. But because NGS report was not available, so we were not sure whether she has anything, inherited bone marrow failure syndrome or not. If you give a normal inherited bone marrow failure syndrome guy a conditioning which normal aplastic anemia intensity, that person will break apart. Only 10% amount of conditioning is needed for a Fanconi guy. You are giving him 100%. The severe mucosity and everything will happen, and that 100% that you will lose that person. So you want to know the NGS. Where is the NGS? NGS report came this. By the time this lady left our hospital saying that you people are doing delay in transplant, so we are leaving. We are going somewhere else. We were not aware where she is. Somehow we came to know she is in Delhi. She was doing transplant in certain center. So we called up the transplant center, gave them information. Please don't give conditioning. They thanked us. They're thanking us till today. That at least you have a diagnosis in your hand. And because she was this heterozygous, so therefore, now look at the one piece of information in this report. You have two mutations of Fanconi anemia gene, exon 24, 31. And this is autosomal recessive. Autosomal recessive needs both the gene on the same. Homozygous only, na? Then how, if it is not homozygous, how it is causing Fanconi anemia? because this is two separate and compound heterozygous. Both genes are complementing each other, and therefore, even if they are not homozygous, they are causing aplastic anemia. Yeah, again, this lady, AML pathology people have asked a lot of questions. One day I presented this presentation, this case to somewhere else. So he was diagnosed to have AML on flow and peripheral blood and bone marrow, everything. We did Ejavin because he was old age and had diabetes. 6 days of EDA, count went up to 75,000. We discussed why this is happening. I've never seen such cases. So everybody says, okay, it's okay, sometime it can happen, you give cytosine 100 and subcut. So we gave cytosine. 8 day, he developed respiratory distress. We did an X-ray, diffuse pulmonary infiltrate. We do not know what it is. Yeah, so C was 10th day he expired. And cytogenetics came a PML. What? Whose mistake is this? Everybody in shock. A diagnosis which you can treat easily turned out to be death because of the somebody was not paying attention. I would not say the pathologist was in hurry or he had not paid attention, because microgranular variant or something like that they can easily miss. Now this is the last thing I want to present. A 27-year-old female with CML-CP, this is important for all of us, on imatinib for 4 years, came to you with her BCR-ABL report. Now analyze the report and tell or counsel her, is the treatment going okay? Can she plan a pregnancy? Now this is the BCR-ABL report, 0.0126. What will you tell us? Which phase she is? So how do we do that? This is the way. Look at the last line. Less than 0.1 is known as major molecular response and it is green line. Yellow is ये जो लाल बत्ती वाला देखा है ना हमने, वैसे ही होता है ट्रैफिक सिग्नल पे. If you see red flag, stop. Yellow, go slow. Watch here and there. Green, fast चलते जाओ. So anywhere during the treatment after 1 year, BCR-ABL less than 0.1, that means major molecular response, you can continue with the imatinib or whatever dasatinib you are giving. Now, if it is not somewhere between 0.1 to 1 in 12 months, that means look here and there. Are you taking medication? Ask question correctly. Compliance is good. Okay, compliance is good. Still it is not okay. Do IRMA, imatinib resistant mutation analysis. Is she developing any mutation? If it is so, then change the drug accordingly. Now, if it is anywhere after 6 months, anywhere more than 10%, that means your drug is not working. Stop the drug, do IRMA and change the drug. Now, this is how the report will come. When you see the BCR-ABL report, the next page will give you this information. So this is the lines you can see here. You can see this MR1, 2, 3, 4, 4.5. MR means 1 log reduction. So when you reduce it from the initial 100%, when the patient will come, always it consider it 100%. You started imatinib, it will reduce to 10. That means MR1, 1 log reduction. Again 1 log reduction, it become 1. MR2, then MR3. So when she come at MR3, he sees major molecular response. This you need for 1 year and around after 1 year anywhere. Now she was here, 0.0123 between MR3 and MR4. Now whether she can plan a pregnancy, of course this is her choice, she can plan, but you counsel her that okay, you need to stop the tyrosine kinase inhibitor. For that you need to achieve a deep molecular response. A deep molecular response is 4.5, MR4 or 4.5. But she is still not at MR4, so you can't take chance of stopping tyrosine kinase inhibitors, because at that point, if you try to stop, 70% of the patients within 3 months will again relapse. So therefore, you need to counsel that okay, for some time you continue for 6 more months and we will repeat the BCR-ABL. If you are 4, we will stop. And during pregnancy, you monitor every 2 monthly BCR-ABL. And if it is 0.1 or around, hold that, no need to TKI, deliver as soon as there, you start TKI. Otherwise, no. Yeah, these are some of the patients, nothing else. Get this small, tiny baby transplanted. This is the Pradeep first case which AML guy who was still surviving.